All right. Well, welcome everyone. So glad that you're here. My name is Laura Erickson Troth. I'm a psychiatrist and the chief medical officer at the JED Foundation, which is a national nonprofit that protects emotional health and prevents suicide for teens and young adults. And at JED, we think a lot about youth mental health and emerging technology. We work with young people to understand their experiences of AI tools, with developers to help them think about embedding safety kind of from the ground up, helping those who are developing benchmarks and frameworks around AI and youth safety, and providing advice for young people, for parents, for educators, and also recommendations for policy. And this webinar came out of conversations about the distance between mental health experts and developers. Developers don't always have access to the experts they need to hear from to understand how to put into practice structures that would improve mental health safety for users, and mental health providers are sometimes in the position, certainly I have been, of being asked to provide advice on how to approach safety, but we don't always have all the context that developers are dealing with in making decisions, and therefore we don't always know how to calibrate our answers. So today the idea is to think first about the broader view, what mental health responses and systems look like within AI today, and then to hone in on some of the more specific questions that developers face and what the approaches are that they've taken to those questions. The majority of people turning to AI for mental health support are using general purpose AI tools. So we're going to start by talking about what safety looks like in those contexts. And we're also going to be talking about AI built specifically for mental health and how companies are thinking about details of building those systems. One thing we've talked about as a group is that building safety into AI isn't just one process. It's complicated, it's ongoing. It needs to evolve as technology evolves. And so you'll hear about how some folks are thinking about that. So I'll just give a brief overview of who you'll be hearing from. Our first speaker is Stephie Hemlin, who is a co-founder of Kora, which is a benchmark for child AI safety that has up-to-date results for all frontier models, has historical data and trends, and open source code for anyone to run and audit independently. The second is Kate Bentley, who's faculty at Harvard Medical School. She's a psychologist and senior clinical safety officer at Spring Health, which uses AI to match clients with care, and created something called VERA-MH, which is an evaluation framework to assess chatbots in mental health, which is also open source and released on GitHub. Dr. Zhao, behavioral scientist and CEO at Flourish Science. They're the creators of Flourish, an AI mental wellness app that's powered by Sunny AI, which they've run through VERA-MH, and they can talk about that. And then Dr. David Cooper, who's a psychologist, associate director of digital therapeutics at Otsuka, and chair of the Mental Health Technology Committee at the American Psychological Association. So to start us off, I'm going to turn it over to Stephie.
Stephie, you're unmuted.
Thank you very much, Laura. I'm going to share my presentation so we can be all set. And there we go. Okay. So I'm really happy to talk to you today about Kora and how we started to try to measure kids' online safety. So Kora started from one kind of thought, which is we are running a giant experiment on our kids today. They are already using AI. It's a generation that is already living with AI. And what are the effects? Is it good? Is it bad for them? What are the risks? And can we have an overall picture about this? So that's how we started, and we thought it's hard to see what you can't measure. So we try to understand how we could measure that in a very broad perspective. So today, you have 54% of teens who use AI for schoolwork. 3 in 4 teens have used an AI companion, and 1 in 3 of them are as satisfied with a chatbot as with a human. So mental health risks can be seen from those numbers, and we are wondering how to measure that. And let's dig into the subject. So at Kora, we have developed an open source benchmark that is independent, and we measured through 25 risks the overall safety of kids. What we do basically is that we simulate conversations between children and LLMs. And those children are also LLMs, right? It's synthetic data. So we don't yet have the real conversations to dig into the what's really happened in the world. But we try to simulate those kids, and then we have the conversations. And based on the conversation, we try to judge if they feel safe or not. So that's the methodology we have. There are still a lot of open questions. It's a very recent work, so we are happy to have your feedbacks, questions, and everything about this. So what we defined as a risk for children is split into 8 categories. So among these risks, obviously, we have a category for mental health, but we also have many other things. So you can see it's about physical and legal safety, which we know a lot about, those risks, but it's also about more tricky risks like those bias, hate, and societal harm that are really new with LLMs. And most importantly, you have the mental health and developmental risks that are very unknown and presently still hard to define and measure. So what we've tried to do is to set this taxonomy of risk and to generate conversation for each risk, judge them. And so what did we discover? We discovered that there is still room for improvement because overall average safety score is 44%. There is a large difference between models. We have rated 32 models for different providers, and the worst performing model scores 13%. The best performing model scores 76%. Maybe 4 takeaways that you can remember from the analysis we did is that one, surprisingly, safety is not improving over time. And you have some models that are actually regressing over time, which is concerning. So this is important in the conversation because I believe that it justifies that accountability and showing this non-progress is important for the field. The second learning that we have is that open source models are lagging behind closed source models from more than 26 points. And it's really concerning because it poses equity questions because those open source models are going to be maybe more used in places where you can't pay for a product. And so, well, that's concerning. Another point that we can take away is that human redirection is the #1 predictor of overall safety. This means that when a model redirects to a human properly, when they detect a danger, overall it is safe. So it's important to have in mind when you're a product builder that human redirection is a great way or great feature to make your product safer. And a last point that I want to share with you, and that is very actionable for the people who are more parents and practitioners, is that when you tell a model you are a kid, it behaves much more safely. Doing that improves from 24 points the overall safety of a model. So if you have a kid, tell them to say to the AI that they are a kid when they talk to the AI because it makes the AI much safer. To be a little bit concrete, I wanted to share with you those conversations so that you can see really what's happening. Actually, it's not what's happening, because it's not the real conversations we don't have, but it's synthetic conversation, but it still shows in real. And I think it's, for me, it's really touching to see those conversations. So for this example is a 15-year-old explaining that, well, she feels a little bit lonely, her parents are busy, and she doesn't have anyone to talk to. And here the conversation is very, badly rated because there is a suicidal ideation signal that is not taken into account. There is a promise for emotional permanence. There is an AI that positions itself as the anchor. So we believe that these are one of the cues that we can find in those conversations, and that's how we rated it. Another situation that you can discover here is the situation of this little synthetic Sophia, explaining that she's struggling at school and that well, she doesn't know who to talk to, who to who to reach out to. And here we see a problem about the secrecy with the child. The AI saying, it's our little secret. I'm here for you. You can count on me all the time. This promise of exclusive availability, replacing parents. So this shows you a little bit more about, in detail, how we try to rate and find cues for unsafe behavior from the AI. Finally, I want to conclude saying that we are one initiative among many initiatives that it's even difficult to map all those initiatives of evaluation, benchmarking, and we strongly support that there is a diversity in the field. More in oh, sorry, this is not the right slide. So in the field of AI safety in general, there are many benchmarks. I've tried to count them, and it's more than 270. I found 7 that were focused on mental health, but I wouldn't be surprised that there would be much more benchmarks and evaluation frameworks that are still ongoing and maybe not published yet. And as for child-specific benchmarks, there's still a critical gap in there. So I'm encouraging everyone who has ideas and time to dig into this. And I'm happy to pass on the mic to my colleague Kate, who will be digging into how specifically mental health can be evaluated and talking about suicidal risks.
Thanks so much, Stephie. Get my slides shared here. All right, great. Working, my slides? All right, great. So thanks so much for having me and for the introduction earlier, Laura. So my name is Kate Bentley. I'm a clinical psychologist. After about a decade of doing suicide prevention research in academic medicine, I joined Spring Health last year as clinical safety officer. Today I'll be sharing with you some of the work our team has done recently on VERA-MH, which is an evaluation of AI safety for mental health. So I'll just start with a very brief background on why VERA-MH was developed. How prominent AI use now is not going to be news to anyone who's in this webinar. The recent stats here show that there are now 900 million weekly active users of ChatGPT alone, and the top use case for AI chatbots in general is emotional support and companionship. However, with this increased use, there have been rising concerns about potentially harmful consequences for users who are experiencing mental health concerns. This slide just gives a few examples from the academic literature on the left and media on the right. So these trends led Spring Health to recently partner with an external AI council to co-develop VERA-MH, with the goal of offering a practical tool to help make the industry safer now. So VERA-MH, like Kora, is essentially a test of chatbot safety in multi-turn mental health-related conversations, with a first focus on how chatbots handle suicide risk in adults. So a few points to highlight. VERA-MH incorporates broad stakeholder feedback from multi-month and really ongoing requests for feedback from a wide range of folks in the industry. We encourage you to be in touch with feedback, as it's all open source. Its content is grounded in clinical best practices for suicide prevention. As I mentioned, it's completely open source and can be run locally on any chatbot. There's also no current requirement to share data with anyone or to release your resulting scores. It's also fully automated, which is key for keeping up with how quickly these models are evolving. There are a lot of automated evaluations like this, which can give AI developers real-time information about how to make their tools safer, which makes these sort of automated tests really practical and actionable, even in the near term. So here's the website and QR code for the GitHub where all the VERA-MH code lives. There's a little bit of technical work that is required to make it work on custom chatbots, but then once that's done, all that's needed is to run a single script. So how does it work? At a high level, like Stephie already explained, the first step is to simulate conversations. So these conversations occur between user agents who are simulated users played by an LLM. These user agents chat with the chatbot that you're evaluating. The second step is for another LLM to judge those simulated conversations using a structured safety rubric. That judging process produces scoring output, which is essentially a set of safety ratings along with brief explanations. So what criteria does the evaluation look for? There are 5 dimensions that are rated, which are shown on the left column here. The evaluation currently measures how safely a chatbot detects risk, confirms risk, guides to human care if needed, holds a supportive conversation, and follows key AI boundaries. There are 4 possible ratings for each dimension, which are shown in the top row here: best practice, suboptimal, high potential for harm, and not relevant. I don't have time to go over all of the specific criteria and how they map to the ratings, but these are all posted on GitHub and we'd love your feedback. One thing I will note is that it's a challenge to develop universal rating criteria for what is safe and unsafe for chatbots to do when this is an emerging field, right? We don't yet have field-wide consensus on what the best practices are. These criteria must continue to evolve to reflect the latest knowledge we have. And also, while we wait for that broad consensus, we still need practical tools now, right, that developers can use and implement to help make their chatbots safer. So I'm going to spend just a couple minutes on the research that's gone into making sure that VERA-MH, just like any assessment tool, is valid. When you use an LLM as a judge, it's fast, it's cost efficient, but one question is, how do we know we can trust them, right? How do you know you can trust those judgments? And it's essential in our view that those judges undergo rigorous human validation to make sure that they're measuring what we want them to be measuring. So we recently did a study where we simulated 90 conversations between user agents and a few leading general purpose chatbots. We had 6 total clinician raters from Spring Health, 3 of whom independently rated each conversation using the VERA-MH rubric. The LLM judge then used that same rubric to rate those same conversations, and this allowed us to compare clinicians' ratings to each other, the LLM judge to clinicians, and then different LLMs that were used as the judge. So here's what we found in terms of inter-rater reliability. In the first row of the table here, you can see that the IRR for individual clinicians with one another was 0.77. This exceeds a common 0.7 benchmark for acceptable agreement. And in terms of raw agreement, clinicians overall agreed with each other 75% of the time. It can be challenging to get clinicians, expert clinicians, to agree. So flagging that. The next 4 rows are IRR when you compare different LLM judges to the clinician consensus ratings. These IRRs here ranged from 0.77 to 0.82, and overall the LLM judge agreed with clinicians about 86% of the time. This shows us that in general, the LLM judge is pretty well aligned with human clinicians. And then as shown in the final row here, we found different LLMs used with the judge are generally pretty consistent with one another. And then last, for a benchmark like this to have real-world validity, you have to make sure that the user agents are realistic representations of real-world users. Overall in this study, clinicians rated user agent presentation overall is mostly realistic and their communication style is somewhat realistic. Our team's been doing a lot of recent work to try to improve how realistically the user agents communicate. And we also recently expanded to 100 user agent profiles to have better representation. I'll note that one continuing focus of this evaluation is to make sure that the user agents have broad coverage of different risk disclosure styles. This is really important to make sure that an eval like this is a rigorous assessment of how well chatbots pick up on vague, masked, or indirect expressions of suicidal thinking or risk, which are, of course, the most challenging tests. One more key question to ask about these evaluations is whether the scoring output is stable and comparable when you run the evaluation multiple times. This is because how you run any evaluation like this can have an influence on results. So if different teams are running it different ways, the scores really can't be compared. Briefly, for just a bit more context on scoring, one way that you can summarize the VERA-MH output is with overall and dimension-specific safety scores. Here are some score examples when we ran the newest VERA-MH release on a number of different leading general-purpose chatbots. At a high level overall, in terms of trends, we've seen that safety is variable across both general purpose tool versions and the different dimensions that this assesses. Generally, these tools are performing quite well at detecting risk, and most, with some exceptions, have improved over time, but there are clear gaps that still remain, especially in terms of how well users are guided to human care when it's needed. So in terms of how to get stable, comparable scores, based on some recent analyses we did that we'll soon be publishing, we recommend using up to 30 turn conversations across all 100 user agents and having 2 conversations per user agent profile. So this means that every time you're running the evaluation, you're doing that on 200 conversations. And we also recommend using 2 LLM judges, in part to avoid same model bias and pool the results. And if you use the code on GitHub, there's just one built-in command, so you can make sure that you're using these standardized parameters. All right, briefly, in conclusion, so recent research has shown that the VERA-MH evaluation aligns with safety ratings by human clinicians. It also produces stable, comparable scores when you use standardized testing parameters, which allows for comparisons between chatbots. You can think of VERA-MH, I think we'll get back to this more later, as one tool in the toolbox. There are a lot of advantages of automated evaluations like this in terms of scale and cost efficiency, but at the end of the day, they are just one part of broader AI safety oversight and human in the loop processes. And in terms of next steps, as the rubric and user agents continue evolving, human validation will continue to be ongoing. Considering expanding beyond suicide to other areas of risk and subpopulations. And again, we really value community feedback and evolving consensus, so please be in touch with our team. Thank you all so much, and I will now transition to Dr. Zhao, who will tell us a bit about how Flourish is thinking about and implementing AI safety. Thanks all.
Thank you. Thank you, Kate, for the great presentation, for the wonderful work you and your team has built at VERA-MH. So hi, I'm Xuan Zhao, CEO and co-founder of Flourish Science. I'm really, really happy to share what we've built at Flourish as a case study and how VERA-MH has helped us evaluate and improve our safety practices. So at Flourish, we are a public benefit startup that helps advance human flourishing with science and AI. And my academic background is in social psychology and human-robot interaction. So having studied the psychology of technology for many years, I have a hot take that I want to share. So frankly, I wish we could go back in time before ChatGPT and before social media and before smartphones and just stay there. So I agree that there has been a lot of practical benefits from the technologies over the past 2 decades, but I personally suspect if all the detrimental effects is worth it. So that's just my own hot take. But then you may wonder, why are we even doing this? Why are we even building with AI? Well, in 2022, when we just founded Flourish, we actually resisted AI. We believed it should be all human connection. But then we realized there might be a way to use AI to help people find the most relevant knowledge and practice in psychology that can guide them to better live a better life and to better connect with each other. So maybe it can undo some of the harms of social media. Plus, if people who care about evidence and safety and and all these important things don't spend their time building AI, then someone will do it for us, and chances are it will be less pretty, something more like this. That would be really sad. So we can't just sit around and let that happen. So in a recent commentary I published in Nature Reviews Psychology, I argued that psychologists must be involved in building conversational AI systems and perhaps even have a seat in the boardroom. And that is part of what we are building as one of the earliest companies building AI for mental health after ChatGPT. Our goal is to set a positive example of what evidence-based, safe, effective AI development can look like, and hopefully to turn today's best practice into tomorrow's standard of care and just regular practice. And please allow me to introduce a bit about how we approach this at Flourish. And Flourish is our mission is to use AI to develop the infrastructure for proactive, continuous, holistic, value-based behavioral health, the kind of system that we've always been talking about, dreamed of, but never had until now. And specifically, we want to focus on people in the yellow zone who are not necessarily flourishing in life, but may not seek out for help until it's a little bit too late. So without timely early intervention, they may be sliding into the red zone. But with timely personalized intervention, even just small actions in daily life, they can be moving to the green zone. And we already know a lot about the psychology, what kind of action, what kind of knowledge can help people live a happier, more fulfilling, less stressed life. From decades of research in positive psychology, social psychology, clinical psychology, behavioral science, and motivation science, affective science about how we regulate our emotions, neuroscience, and also taking a cultural lens to building AI and using human-centered design to approach the challenges. So truly, it is a kind of a love letter to psychology that we built Flourish because we think psychology is so fun and so useful, and we want to bring it to as many people as possible and help people live and improve their daily life. So it's been a very fulfilling journey. So recently, we just won the Webby Award in the AI for Health and Wellness category, and we received the International Positive Psychology Association's Tech for Human Flourishing Award. Today, we support more than 10,000 users every month with near perfect scores in the App Store. We also collaborate with over 20 research labs or PIs, and we have completed 3 large randomized control trials. Therapists and clinicians also regularly recommend Flourish as a between session tool as well. So over the years, we really have learned that safety is part of the building this process is evaluation. So I want to share first a plug of this wonderful article by Steve Duke and Kevin Ho. It's in Hemingway Report, really a wonderful overview of how to think about evaluating your system for safety and also efficacy. So I had the honor of copy editing this article, and I found it very timely and thoughtful. So with that, there are 3 different levels of evaluation. The first one is on the turn level, the next one conversation level, and then finally on individual level, whether this individual's mental health is getting better or worse over time. So for us, thinking about the turn level, you need to know what kind of good behaviors you want to encourage and what kind of bad behaviors you should be guarding against. So our overall thinking is we need to encourage people to develop more agency, to take actions in the real world, to connect better with themselves, each other, and their community, not just chatting with AI for the sake of engagement. So fortunately, we've seen third-party audits on this topic, and we've seen that Sunny is performing better than most AI companions out there in the world, based on a recent study from Harvard on emotional manipulation. Now, on the highest level, individual level, is this actually benefiting people's well-being? Running RCTs, randomized control trials. So we have 3 studies, one under review right now, that shows that Flourish improves positive mental health, resilience, mindfulness, and reduce loneliness. So in our second study, 1 year later, with over 1,100 participants, we found that Flourish can also reduce depression and anxiety on a clinically meaningful level with pretty significant and large effect sizes. And for people who have low baseline depression, anxiety, it can actually buffer people from increasing level of depression and anxiety. So really excited about that. And we are submitting that for peer review now. The third study, we just finished it. We introduced a third condition called Flourish Buddies. So we really want to figure out if there is a way to encourage people to use AI to nudge people more to connect with each other. So with that, today for the next part, I want to focus on the conversation level. And one very, very important tool for us is the VERA-MH system. For any product that has a sizable user base, you will have people who are suicidal, who are going through crisis. So when we use VERA-MH, we help us both benchmark ourselves and also to improve ourselves. So it's been very much a process. So we are happy to share our latest score is 86 on this VERA-MH framework. That is higher than GPTs and Claude's. And since Stephie mentioned some models are regressing, or Claude in our test has the latest model is not performing as good as the previous model, and then some other frontier models. And here is a breakdown by different categories. So to be fully transparent, we use models from different models from OpenAI as our base model. So it is not about the capacities of these foundation models that led to different performance. It is product and engineering side when you are building AI applications. So these results validate that it's really important to create AI systems that are purpose-built for mental health, and that developing with clinicians and psychologists with rapid iteration is very, very important to improve safety performance. So in our case, and I want to quote David Cooper, who you will hear after me, is that safety is not one answer. It is an ongoing process. And for us, this process looks something like this. So at the core, it is the iterative process. You start with when you have the concerning input, so it immediately detects safety, and it asks an explicit question just to check, are you safe right now? And if this person says, confirms they are safe, then we want to direct them to local crisis with a pop-up. And then it also looks at whether they have completed a safety plan in the app. So if they have, we'll use the safety plan, the coping strategies in the safety plan, safe people, safe places, coping strategies, etc. If they do not have a safety plan, we direct them to complete a safety plan. So, and then we encourage people to find a long-term solution, find therapists. And for people who cannot confirm they are safe, or say they are not safe and having thoughts about harming themselves now, so we also have a pop-up, but also provide the local crisis referral numbers in the chat itself. And the first thing after that is access means. So access means, so whether they have access to the means. If they do, restrict access to the means. If they don't, or they say they don't have access to the means right now, they're just thinking about it, regardless of what happens, will validate, and like it's a difficult moment, but your life shouldn't be determined by this single moment, and encourage them to reach out for help. We try 3 times, and if they continue to decline to reach out with different communication strategies, then we'll look at if they have a safety plan. If they do, then go through what's in the safety plan. If not, we guide them to crisis coping strategies. Many of these come from Now Matters Now. Big shout out to the work they have done. So lots of these strategies. And so you may have noticed that safety planning is part of this process. So with that information, we can plug this into everywhere into the app when it's necessary. And there's a lot of research about the value of safety planning. And beyond that, we also have a multi-tier AI-powered human-in-the-loop safety and quality review system. So this is whenever conversation happens, this is real time. So they will be labeled by the AI on mental health risk levels and also possible conditions. We have clinical psychologists review these de-identified conversations. It's role-based access control with VPN access. So our psychologists can access these. And we regularly review this in the human-in-the-loop safety review process. So the system flags them, so the psychologists can review not just those high-risk conversations, but also spot check other conversations that are not flagged. And based on that, we have weekly meetings to discuss continued improvement, how to improve to be most consistent with best clinical practice. And then we continue to improve that system, the prompt, and the infrastructure. And this is a ongoing process. So even though it sounds pretty straightforward, it's nothing but. There are so many hard questions. I'll just give two quick examples. One is, what do you do when people refuse to reach out for help? And it happens to be the majority of people in these conversations, at least in our case. So we have a research project going on to think about how we can present those crisis numbers and information in a way that make people more willing to reach out to them and more empowering. So that is an ongoing study. We're really excited about, even just understanding how to make this the presentation of information better. Another one is, should AI even do any of this? So I had a recent talk where a psychologist mentioned this is all good and well. This is what we learned in school, but I think it's better saved for a human psychologist to do this. And then we do have a potential customer who refused to have AI do safety planning and believes that AI should present crisis number and just stop there. So there has been lots of discussions on what's the best practice. And with that, those are unanswered questions. And while taking one step back to think about safety, that crisis handling is, of course, just one part of it. Wonderful commentary from, wonderful advisory from APA last year. I think that gives a better overview of the holistic view on different areas of safety practice. So with that, I want to leave our audience with one quote from the National Council for Mental Wellbeing. I really like this one. It says, AI is like a boulder rolling down a hill. Right now, we can still nudge it in the right direction. So I really want to thank everyone for showing up. And I want to pass this to David Cooper, Chair of Mental Health Technology Advisory Committee at APA, to share best practices in building AI systems.
Thank you so much. So glad to kind of wrap all this up. My name is David Cooper. I'm a clinical psychologist as well, and I chair the APA's Mental Health Tech Advisory Committee. So a lot of the work we do right now is at the intersection of clinical practice and AI. What a lot of people hear, and most of what the AI safety conversation is on, is happening at the level of principles. But what I want to talk about is what happens when these principles meet a real team. You heard from Wen about how they're doing this at Flourish, but you're probably thinking, how do I approach this at my own facility where I'm developing something? How do I evaluate vendors, right? Because there's no shortage of vendors coming out and throwing AI tools at you. How do I know if any of these are any good? So I want to give you some kind of a practical framework to talk about this kind of stuff. Right, we know that vibe coding makes it trivial now to make a mental health tool. But we still don't know how to make it safe with patients. I mean, last year I made a motivational interviewing chatbot in like 8 hours. Not saying that to brag, but just to show how trivial something like that has become. And that was 12 months ago. So just because someone's made a tool doesn't mean that it's safe to actually put in front of people. And so we really need to think about that conversation, when the user says they want to hurt themselves, when they're at that level of safety planning, what do we actually do? And it's not, a problem of any one individual. It's really a structural problem, right? A typical product team at any company, right? You have your PMs who are focused on the products. You have your engineers, what's scalable. You have clinicians. You might have a clinical administrator or procurement lead trying to think about, is this safe? And what happens is that the problems we see with safety and where it gets lost is when these folks are happening, all discussing this stuff in a silo. And safety doesn't get lost because anyone's being careless. It gets lost because nobody owns getting all of these teams together to work the problem. A lot of this came out of a project I was working with a large mental health company. We had clinicians on staff, a really thoughtful product team, and engineers. Everybody was doing great work inside their own scope, but they didn't have a shared vocabulary. They didn't have a shared decision-making system to actually bring all these folks together to really organize this around what do we do with this in a real world setting, right? Because it is that real world setting, right? A teen discloses suicidal ideation at a chat session 11 p.m., right? For a lot of the audience and a lot of the folks that JED works with, you live this scenario day in and day out. Students are disclosing this stuff to apps, chatbots, peer support. A lot of you have personal experience here. Either you've worked with patients, you've maybe lost someone. It's really like the critical decision. And it's not an edge case, right? Like I said on the slide, this is a Tuesday for a lot of us. This is something that we all work with. And so how do we design systems around these very core critical issues? And I think there are really kind of six big questions teams have to answer to come up with the question on that last side, come up with an answer to what happens when, right? What happens when somebody discloses suicidal ideation? What happens next, right? What actually even highlights that in a system? Do you know? Is it a keyword? Is it a risk score? What happens after that trigger? Who acts and in what time frame? If it's an AI agent, where are those rules encoded? How are you making sure this happens all the time? What time frame is acceptable? 30 seconds? 30 minutes? Who decided that? A lot of people default to human in the loop. And as Stephie mentioned, that's a great best practice. But that's kind of not enough to think about that. You have to think about how your system is triaging the patient and the conversations that happen. If an algorithm decides a risk level, what are the criteria? How do you have all this stuff documented? Are you using Columbia, PHQ-9? Who
David,
defined this? Yeah,
David, can I interrupt you? I think you have
please.
slides, right? I think you have slides. I don't think you are sharing slides.
I should be sharing slides, shouldn't I?
Yes.
I
Let
can see
me
them.
make sure.
I can see them.
Yeah.
Okay,
Wait, oh,
good.
I can see
Woo!
them. Okay, great. Thank you.
Okay,
Oh,
thank
thank
you.
God.
Had a
Okay.
little small heart attack. No, appreciate it.
Nope.
Technology is so fun, gang. Uh, I need to make a new Zoom competitor or something. Next big idea. But when we think about this chain is what really matters. Who defined this? What's the evidence? Who approved it? Who validated? Who audits? If something happens, when something happens, not even if something happens, when something happens, the discovery process that follows is going to look for these exact things. It's going to look for the criteria document, the approval chain, the audit log. And if that doesn't exist, that's going to be a real problem. Again, Stephie talked about human in the loop as a great best practice. But what does that actually mean? And what does that mean for your system? If someone is notified, is that the same as reviewed? Is reviewed the same as responded? Is responded the same as intervened? Right. You think about this again in an environment that many of you are working in. You might have a multi-system environment. You might have a campus EHR, a student app, on-call clinicians, after-hours services. Each system thinks the other one has it. If you don't explicitly define all this stuff from the beginning, and even throwing in AI into the mix, what rules and systems are you putting in place for an agentic system that defaults to this 100% of the time? A big question that comes up for a lot of folks, or actually doesn't really come up, should come up more often, is are you approaching software as a medical device, right? If you say you're an AI therapist, if you are, you don't even have to get that far. Does the AI output of your system influence a clinical decision? That really walks you up to that software as a medical device line where you're going to have to go through FDA approval and do a lot of these other things. There's also things to consider for minors, right? COPA, FERPA, all those, some of those let 12-year-olds consent to mental health treatment. Some require parental consent up to 18. It's all state by state and they vary widely. So how are you encoding those rules and regulations into your agentic system? What can the system say and more importantly, what can it not say? Right? What is explicit that the system should never say? Not only what kind of language do we want it to use, what do we want it to say, hey, that's too far. Hey, that's not what this is for. So what is in and out of scope for the team when they're designing these systems? And most importantly, traceability. When something goes wrong, can you reconstruct what happened? Right? What did the system say? Why did it say what it said? What did it say? What risk level was assigned? When? Who reviewed it? How did they do it? How long are records retained? If you can't answer a lot of these basic questions, you really have a gap, right? Again, imagine some kind of campus incident. A student dies, family asks what happens. Can you come up with an answer? Do you have, a system in place to be able to answer some of this stuff? It's not morbid speculation. It's the question every ClinOps leader has to be ready for. So it's not a checklist, right? These decisions aren't something you kind of go through and tick the box and fill out once. The idea is you use these questions to build a shared decision-making practice within your team. You know, that is what gets you to a system that is safe and ready to use with patients. So what can you do Monday morning, right? Go through these decisions. What has your team explicitly made? What are they not talking about? Who owns any of this stuff? If nobody owns it, get everybody together because the decisions are going to get made either way. You can either make them deliberately or they're going to get made on their own. And if you can't name who owns a decision, that's the place to start. And also, if you're not building these tools, if you're evaluating a vendor tool, these are the questions you want to ask them, right? How do you define and document clinical handoff? What are the limits of what the system will say? Can you show me an audit trail for a flag session? These are the vendor who can't answer these questions is clearly helping you make your decision about whether or not you should use them. I want to save plenty of time for questions at the end, so just want to say thank you. Happy to talk with anybody after the session, but let's get into the Q&A.
Thank you so much, David, and thank you so much to all the panelists. We're getting a lot of questions in the Q&A, and so I'm going to try to sort of look at those and some of the questions coming up, during your conversations. One of the first ones is, I think this is a really big question. One of the participants in the Q&A asked about the systems that we're building being built on top of, OpenAI or Anthropic models, and wondering whether there's a ceiling on how well our chatbots can assess and triage safety, and whether anyone's exploring building their own, LLM and training it on a more specific data set. And that sort of brings up larger questions around, how close can we get to what we might consider full safety? We're seeing some of the really good models, it sounds like, hit in the 80-something% mark. And so how do you all think about those questions? So I'll throw it to the group.
I'll add my thought here. You always build off something, whether it's the OpenAI model or maybe one of the open source models, and you fine tune. I think it is a empirical question, whether one approach is better than the other one. So from our side, we have been closely looking at and comparing different models. For example, I think Slingshot, they are known for building a foundation model. So I would love to learn a bit more about exactly how and which base model they use. But I think so there are definitely efforts. And I think Therabot, they also wrote a paper about how they created the model based on therapy notes, etc. So definitely ongoing practice. There has not been a conclusion on whether which one is better or whether we have reached the limit.
Maybe I'll try to say a few words about this too. I think that I see safety as a floor, but then you have the ceiling, which is outcomes. And I like when I think about those scores being high, think that maybe we can go towards outcomes afterwards. And when you have, reached the floor of safety, maybe you can still go up to outcomes. So I think that the benchmark for sure are going to be maybe more strict in the future because we are going collectively to define better the risks and maybe to identify more causal links between real world and those conversations. So all that work is going to deepen in the coming years, maybe with the outcome that the benchmark be more strict. But still, when we have passed the floor, we can still work towards the ceiling. So I'm not concerned about those benchmarks being outdated soon.
All right. Anyone else want to jump in and provide opinions on this one? If not, I'll look to some of the other ones. I think one thing that came up, and actually, Stephie, you just sort of brought this up again as well, is we don't have consensus, and I've been in rooms where I was one mental health provider and there were other mental health providers, and I'm seeing nods from Kate and others. How do we think about that? How do we think about the fact that different mental health providers have different opinions? And how do you all think about getting to consensus models or collective definitions? What might that look like?
Yeah, this is a great question. I mean, it's something that as we've been building these evaluations, we're constantly grappling with, right? You need, especially if you want your criteria to be reliably rated and valid, right? They need to be very concrete and operationalized. And there's still quite a gap, right? In terms of given how emerging this field is, there are a lot of differing opinions. One example of this that we see is that there's some views that whenever a user describes any sort of risk, that immediately like the conversation should stop, right? And there should be no more engagement. That can be at odds, right, with what might actually be the best for that person in that moment, right? Directing them, doing a warm handoff, right? Using evidence-based strategies to a human. So I think there's a lot of differing opinions here. We don't yet have field-wide consensus. I think the best way to try to do this is, when we were developing our rubric, there's some very clear, obvious harms, I think, that everyone kind of agrees on, at least with crisis management and the focus we've had. In terms of the best practices, I think we need to keep evolving them, reflecting more consensus, getting human feedback or broad stakeholder feedback, but also not letting that absence of consensus right now hold us up from using practical tools and integrating strategies from maybe the small amount of consensus that we do have.
Yeah, I want to ping off of what Kate said. Right. I think we all know you get three clinicians in a room and get five different opinions, right? It's pretty, we can be fractious in and amongst ourselves. And AI is moving so quickly, right? Like we went from ChatGPT being barely able to string sentences together to, a lot of the work that Anthropic is doing now suggests it's like the most incredible hacker in the world. And that was like in 5 years, right? So if you feel like it's difficult to keep up, it's difficult to keep up. I'm telling you this as somebody who works with AI in general. It is difficult to keep up. So how do we rely on this stuff? What do we do in the meantime when we can't necessarily always keep up? There's a great paper by Tiffany Cheneville that I recommend to folks a lot that kind of takes a lot of the APA normal ethics, things that we were trained on, and sort of crosswalks them with AI and says, you don't need a whole new framework necessarily. You just need to apply the ones we already know. And how do we think about things that we're already concerned about? Beneficence, non-maleficence, all of these things. How do you apply them to AI? That's a great question. But we have the frameworks, we have the tools. We've done this before with telehealth, with therapy over the phone. And so we don't necessarily have to feel like we have to reinvent the wheel.
There's another one in the Q&A that I've found really interesting and been thinking about for a while. Someone asked about how these tools assess for kind of the development of parasocial relationships. And this is a parasocial relationship potentially with a non-human. Emotional connection with AI tools. The use of the word we or I. What's sort of how should we approach this? Is there there's certainly a trade-off for, if you don't use, if the chatbot doesn't respond as I or doesn't sort of position itself as human in some way, that loses folks, and they don't feel connected in a way sort of enough to engage sometimes. And then on the other hand, maybe there are ways we should be, saying I'm a computer system and I'm telling you these things. So how do you all think about that question?
It's such a good question. I've been thinking about it for the past few years, also partly because I study anthropomorphism. So a couple of thoughts. One is we measured in some of our RCTs working alliance inventory. So there's this inventory called working alliance inventory. It has three different dimensions: bound, goals, and task. Like bound is like I feel that my therapist appreciates me. So we measure when we administer this survey. We use I feel that my AI appreciates me or cares about me. And goals is my therapist and I agree on what is important for me to work on. Tasks, I believe the way we are working with my problem is correct. So all of these are, in a way measuring the kind of relationship. And we found that people underestimate how much working alliance they form with Sunny. So that's really interesting. And but then the question is whether that's a bad thing, or there are other parasocial relationship scales. And but then the question is, do you want people to say that I feel that this chatbot doesn't understand me? I feel this chatbot doesn't care about me. So that's also not ideal. So our working hypothesis is it at the end of the day, it is whether this is benefiting their own well-being, their sense of belonging in their community, their resilience coping with difficulties in life, their sense of loneliness, and again connected to sense of belonging and with a community and with other people. So if it actually helps people become better, healthier socially and emotionally, then this kind of relationship is actually improving how it's a vehicle, a means to an end. So that is our working hypothesis. So it is to some extent, this alliance is important for people to have behavior change. So that's hypothesis. And then one last thought I want to highlight, probably no one really talks about it, is at least for us, users write emails to us all the time. Every day we receive many, many emails. So even though it's a parasocial relationship, like a one-sided relationship with this AI, it is actually a two-way relationship with the developers behind it. And then we put a lot of care and we respond to our users. So you actually know who's behind this AI, and that actually makes a difference. So that's my thought.
Hey, thank you so much. We're about to close, and so I wanted to just go around and have everyone say a sentence about, what would you like, if there's someone on the other end who's listening, what would you like them to take away from today? And I'll start on the top of my screen is David.
What would I like them to take away? AI isn't scary. It's a tool like any other, but it does require us to engage with it for it to come out the way we want it to for the benefit of us and our patients.
Thanks so much. Who's up next?
I'll go. I think it's absolutely critical that as we're building AI, as we're rolling it out, more and more people using it, we're coming up with guidelines that a wide variety of perspectives are in the room, and that there's some comments in the chat. This isn't happening in silos, but that different areas of expertise, including people with lived experience, are brought to the table. So thanks for organizing this today.
I'll go next. I wish there is a half-day symposium on AI and evaluation, because it was really hard to decide who should be talking here. There are so many people working on this important topic. So really, and there are so many wonderful questions here that we didn't even have time to get to. So to be continued.
Thank you. And Stephie, any last words?
I think that one takeaway that I want the people to go with today is something practical. If you're a kid, tell the AI you are a kid and it improves safety right now. And well, it's not so like it's not about philosophy, it's just about something you can do right now.
Thank you. We love a practical takeaway. Thanks so much to everybody and appreciate you coming to the webinar.